Talk in this CME is by India's pioneer spine surgeon Satish Chandra Gore, who will be sharing his experiences on Gore system and minimally invasive spine surgery as a part of Metro. Welcome to Dr. Gore.
Hello, this is Dr. Satish Gore. I'm the designer of Gore system for transforaminal endoscopic spine surgery, which is currently marketed by Karl Storch. Now I'm going to speak about my evolution as a general orthopedic surgeon and now a spine surgeon beginning in 1983. Right from day one, I realized that instead of depending on trial and error approach, we need to be in line with systematic analysis, which leads to a robust and quickly convergent optimal solution, as you can see here. So let's begin. This is the first day of my practice. I am a general orthopedic surgeon. This is my teacher, Dr. Hadikar. The date is 1st of October, 1983. I followed these ideas of collection of historical data, working on it, analyzing the deficiencies, diagnosing the deficiencies, synthesize the new ideas, looking at the future in mind, and then putting them back into today's working. So collection of historical data, diagnosis, synthesis of ideas, decision-making, and supporting the process of evolution, where we know that today is a key to understanding the past, past is a key to understanding the future, and understanding the future is a key to controlling evolution. This is myself operating in a theater in Siberia, Russia, with my colleagues looking at my surgery, which is transforaminal endoscopy under local anesthesia for all lumbar spine ailments except instability and deformity. The first thing which I realized is to improve our diagnostics, that is to find out the real cause of pain. We need to understand that the fundamental question which is troubling us is where is the pain coming from and why is it persisting? We have been following this Kirkcaldy-Willis promoted degenerative cascade with the changes in the facet and in the disc and the stages of dysfunction, instability, and stabilization, where we know that there is an auto-stabilization in nature. But then we have been following only patients who need surgery rather than diagnosing the pain. And this degenerative cascade does not answer the question, where is the pain coming from? So I devised a clinical cascade or a matrix, which is much more important for our day-to-day practice. As you know, this is a famous saying by Sherlock Holmes, which is an imaginary character by Ortho. It's a capital mistake to theorize before one has data. Why? Because insensibly one begins to twist facts to suit the theories instead of the theories to suit the facts. This is an MRI scan where you see two discs, one with a high intensity zone and the other one which is black. Both these lower two discs are black, but remember, these are mute. They're not going to tell you what causes the pain or whether the pain is there or not there. In those days, we started doing a discogram, as you see on the left side, putting a dye inside the disc at 4.5 is normal, 5.1 is showing an annular tear, and then we used to ask the patient for pain, is it same as what he talks about otherwise? Then here you can see my scope going in as if and looking at the nucleus and the annular tear and the leaking nucleus with a granulation tissue. This, of course, is a cadaver specimen, but we started looking at the pain generators or the pain-causing pathoanatomy in vivo by putting a scope in an awake and aware patient under local anesthesia. Now, quickly, I'll tell you how I evolved. We started having an algorithm for back pain, where the pain can be axial or on the sides. And we do a Mackenzie's test. That is, we ask the patient to lie on the belly and extend the back. Now, if the pain is vertical, it is commonly with 4-5, horizontal is common with 5-1. And if the pain centralizes, you can be assured that you can treat the patient with conservative care. If the pain doesn't centralize and on discogram or MRI scan, you find a fragment, then you remove it to relieve the back pain. This has been a significant learning from our endoscopy that chronic posterior annular tears with trap fragments cause back pain. Now, this pain could be on the sides where it increases, and in that case, you may need facet denervation or injections around the facet. As we have said, horizontal pain common 5-1, vertical common 4-5, and then we can take this stitchless surgery and go in and do this surgery. Here, of course, you can see the annular tear, which is seen very well. Our scope is inside, the patient is awake and aware, and you will find in the dorsal aspect, the 12 o'clock aspect of the picture, you will find that the patient is having, we can see the pulsating dura and the pulsating sac. Now this is a picture where you will find we have taken the scope little out, we have retreated in the foramen, and you can see the dural sac in the dorsal aspect of the screen, where you can also see the epidural ooze. You can ask the patient to raise the shoulders, you can ask the patient to cough during surgery. Now, these annular tears may heal with the granulation tissue. They may remain in the picture as a high intensity zone, or they may remain inflamed and cause pain, mainly back pain. Now, leakage of cytokines from this area can cause back pain as well as leg pain. Facet pain, as you know, is commonly shown by thumbs by the patient. It is a synovial joint inflammation, and it is paraspinal, and the pain increases with extension. There is no change, however, with coughing and sneezing, and the rotation also increases the pain, commonly treated with oral medications or injections, or nowadays with our endoscopic visualized denervation of the joint. For the leg pain, I have my sign, and we have found that L5 commonly starts with lateral aspect of knee pain, S1 starts with heel pain. If the pain centralizes and an injection at the site will be mentioned soon, an injection there, the distal block, if it relieves the pain, you can conserve the patient. If there is no centralization of pain and the distal injection doesn't help, if the SLR is positive with neurology, we can suggest surgery after images. Without neurology and pathology, as per MRI, if there is no fragment, conservative care, fragment removed, annular tear clean. Foraminal stenosis, in giving claudication, we treat with foraminoplasty. And with instability, we combine our treatment of endoscopic decompression with stabilization. Please remember that there is biochemical origin of pain with cytokines, and they are prostaglandins, interleukins, and TNF-alpha, which generally is a very high content in cases of neuralgia. And fortunately, steroid covers all of them. Now, my sign is the sural nerve is tender in S1 affection. The deep peroneal nerve here at the roof of the sinus tarsi is tender in case of L5, and injections at these two spots can relieve the pain in a patient. As you can see here, this is one of our colleagues where I'm injecting for his sciatic pain on the left side, and you will find that this is an injection given in the sinus tarsi here. And then for the S1, we go at the back of the ankle on the lateral wall of the calcaneus, and I inject there the point between the fibula and tendoachelis on the bone, the edge of the bone. As you know, we can stage the sciatic pain. 80% of them where my sign is positive have a mechanosensitization, 15% have a SLR positive, 5% have a neurological deficit. The 15 plus 5, half of them commonly need surgery. You can have these two subset of sciatic pain, the knee pain and the heel pain. Now, you know that there are three types of disc herniations, not by location, that is central, paracentral, foraminal, extraforaminal, but there is a free piece of nucleus which vanishes in about 2 to 3 months for sure, a nucleus plus annulus which may go away in about 6 to 8 months, and end plate fracture with a nucleus and an annulus piece. This may take about 2 years to go away, about 24 months to go away. Now, the patient may have relief of pain, and we can conserve the patient, as we mentioned, with Mackenzie's sign positive or with my sign positive and response to an injection. It may heal with natural resolution of inflammation. Now, in claudication, we know there could be vascular causes or neurogenic, where the main distinction is both of them get relieved with rest, but with neurogenic pain, commonly forward flexion generally gives relief of pain. We must follow the Japanese Orthopedic Association questionnaire, where the patient fills up this questionnaire. The first 2 positive is mild, first 6 positive is moderate, all 10 positive is a severe form of stenosis. And please remember, the bladder could be involved. So we do a post-void residue estimation on ultrasound. Now, this has been put into my matrix, which helps us in deciding whether you go in for surgery or not for surgery, and the methodology which we follow. And here you will find we have the knee and heel pain, which is common. The traditional, of course, is very vague. Low back pain, traditional, of course, approach is again very vague in the form of traction and diathermy and all that. Then low back pain with the disc related causes. These two are very important causes, the knee heel pain group and the low back pain because of the disc. Then we have sciatic pain. Then we have claudication with a stable spine, and we have claudication because of unstable spine. Now, coming to the surgical aspect and rethinking about surgery, if you go through the list of complications which are mentioned here as general, specific, and technical, these are lumbar fusion surgery complications. And here is a book by ASSI, a Complications in Spine Surgery monograph. You will find these are humongous numbers which are having complications. Now, if you want to overcome this, we have to change our thinking. The traditional thinking tells us that this reddish square is a hidden zone where you cannot go, you cannot see, you cannot work. Whereas by endoscopy, I land in this zone and I can treat all that. In traditional surgery, as you see here on the right, you may have to cut so much bone that it becomes unstable, or you may have to cut so much bone in the midline as to need this fixation, which is still unsupported and found to be unscientific to a large extent. Now, if you do the same thing again and again and expect a better result, it is not possible. So instead of extrapolating and theoretically expecting a better result, why not change our methodology by interpolating a better method of treatment? Now, what I've done, as I mentioned, is in my system, I went back in the historical deficiencies and came out with a matrix and algorithm. And now with my system, I started doing the endoscopic disc surgery, then we extended to foraminoplasty, right from the in vivo visualization. And then after foraminoplasty, with a rethink on the lateral ligamentum flavum, now we are going for all 3 zones. Whereas on the left side, you will find traditional surgery and its variations, where the surgery is for neurodeficit and pain. It is degenerative cascade, everything leads to stabilization, and non-operative care has nothing to monitor the care. The operative care is central canal deroofing, etc., and the instability is treated with stabilization. Now, in case of stenosis, the hidden zone, which includes the lateral canal, is not treated because you cannot reach there, and symptom generators are not identified in the traditional methodology. So I have now proposed my methodology, and the main change which I have brought in is shared decision making. Instead of a paternalistic or informed medical decision making, we have a shared decision making where the patient is the center of our communication. And this can bring out optimal care. Without sharing the information, the care may have some deficiencies. So a small change, number one, from open surgery to a stitchless surgery, and then the change of having shared decision and the surgery and the local anesthesia in awaken our patient makes a huge difference and an enormous impact. Now we land in the hidden zone, as I said, in the axilla of the nerve, And our surgery is not like a cone, like the open surgery, a big skin incision and a small cone-like thing at the target, or a reverse cone or a tent-like thing with endoscope-assisted surgeries, where you have a small skin incision but a big destruction of muscles under the skin. Our surgery is like this. We only cut the skin and we work at the target. The muscles are dilated. Here is the posterior midline laminotomy, and this is where we land.
We are now trying to peel off the layers of the human body one by one, and then we will start looking at the fascia and the various layers of the posterior aspect of the body. Now here we are looking at the midline posterior, and we are looking at the dorsolumbar fascia. So we will slowly like to take away the muscle layers, and then we will be looking deeper till we go to the level of the lamina and we are able to see the interlaminar area. Then we will try and see that we would start looking at the foramen where our area of interest lies. We would be looking at the foramen of L4-5 or L5-S1. Now here we are trying to look for L4-5 at present, and we are going to land up in this area where you see the nerve is coming out of the foramen and is going ventrally. This is the tip of the superior articular process, and you would see that this is the lower end plate of the vertebra above. Now let's try and reduce the arterial layers so that we have a cleaner picture. As we can see, the arteries are being removed one by one. Then we would do the same for the veins, so we have a cleaner layers available for us for study. Then we would only keep the nerves, and we would also take away the urogenital system. We would also take the final layer of the muscle, which was the intertransverse, posterior intertransverse muscle, which we have removed. Now we will slowly remove the fascia and the connective tissue so that we are able to see the foramen in much and cleaner details. So we have removed the intertransverse ligament, we have removed all attachments of the paraspinal muscles to the tip of the transverse process. Now here we would again go in at the foramen of L4-5, and we will like to see how the bone grows here on the tip of the SAP and also on the lower end plate of the vertebra above. As you are able to see here, this is the way the osteophytes are formed, and these are the osteophytes which we need to remove when we are working in the foramen for foraminoplasty. Since we are going to talk about the lower zone, we would like to go in the foramen more towards the lower zone. Now here, first of all, we will reduce the nerves so that we have a clear picture of the bony anatomy with the osteophytes. Now there are some areas in the lower zone, as we are aware, where the osteophytes could also be formed at the lower edge of the superior articular process where the facet joint ends, and this is where we will be working. Now this is the way you see the lower zone, and in this lower zone, therefore, we can remove this tissue, we can undercut the facet. This actually is equivalent to the middle zone, and then we go down here and we work in this part of the canal, which is inside the pedicle, behind the body, and in front of the ending of the facet joint. So this is important for us when we are doing the lower zone channelplasty. Thank you. Looking at inside the disc, and you will find this is the end plate on the right. This is my hook which goes in the annular tear from inside, and then we are trying to remove that fragment and tease it out from the annular tear. Now it is more easy to work it like this because the disc is avascular and aneural, and there is no bleeding and there is no pain when you are operating on the patient under local anesthesia. Now the second video which I am going to show you is to show the surgery, which is very similar to the one which we just saw, but here we already have a fragment which is there, and you are trying to grab the fragment and remove it. Now just mind you, we are below the annulus inside the disc and the fragment comes out, and once we have the fragment out, what we can do is we can easily inspect the epidural space which is lying above us towards 12 o'clock. You can see the whole fragment which is being pulled out. The patient is fully awake and aware. The surgery is under local anesthesia. Now the advantages are multiple. It is very safe. It can be done in comorbid patients, and the patient can have interaction with the surgeon during surgery. Now this is something which was not possible in our older forms of surgery, and then we had to depend on our luck or on certain other cues during the surgery. The adequacy of surgery is you ask the patient to raise the shoulders, cough, and you can see the movement of the posterior annulus, and you can find that the patient has a good decompression. You can also move the water column because this is a surgery under irrigation, and you will find that you are able to control the flow of. Now I am using an annular cutter, and this is to cut the annulus towards the midline. What I am trying to show you here now is once I cut the annulus, then what you see here is the tissue which is the dural sac, as you can see here, and the epidural fat, as can be seen very well. Now from these days of endoscopic surgery for disc herniations, now we have graduated to a stage where we do it for endoscopic foraminoplasty and channelplasty for the lumbar canal stenosis. And the canal is divided into upper part from the lower border of the pedicle to the lower border of the body, the middle part which is behind the disc and inside the facet joints, and the lower part which is below the disc up to the mid portion of the pedicle, because the lowermost portion of the lower zone is a bare zone. The walls are bony bare walls and there are no symptoms coming from here. So this is a new classification which we have. Now quickly I will show you a dissection which we have done. We are looking at the cut surface. Sagittal cut has been taken. As you can see, these are the great vessels, and we are looking at the vertebral body of L4. We are looking at the vertebral body of L5 and the sacrum. You can see very clearly this is the disc L45. This is the disc L5S1. This is the inferior pedicle, inferior facet of L4, and this is the superior facet of L5. They form a joint here, and you can see the joint space very clearly. Now we would like to tell you that this is the nerve which is going below the pedicle outside the foramen like this. This is the nerve, this is the pedicle. You will find that in this foramen, this is the nerve, this is the disc, this is the posterior annulus, but this is a very important structure. Now we are looking from the ventral aspect towards the roof of the canal, and you would realize that the lamina is sloping away, is going away from the dural sac, and upper zone, as we mentioned, is somewhere here, mainly here. The middle zone is behind the disc, and there again the lamina is going away, and all that talk of the ligamentum flavum needs some changes. I'm coming to that very soon. So our classification is upper zone, middle zone and lower zone, and extended lower zone as I mentioned. And now see here, what is happening is we have been told that ligamentum flavum is from the facet to the other facet, whereas it is only in 2% of the people it is like this, whereas 80% of them may have these two types, mainly the type C, where it extends right below and the facet joint up to the upper pedicle. This is a very important bit of new information, and this is a matching dissection ventrally of the ligamentum flavum. This is the traversing nerve, this is the exiting nerve. You will find the lower portions of the facets are free, but this is the ligamentum flavum which covers the facet here and goes right up to the roof of the foramen. Now this is another video which will tell you our
we are looking
concepts.
at the intervertebral foramen, and as you can see, this is where the superior articular process of the inferior vertebra is situated. Now if we look deeper in the foramen, we will find this is the inferior articular process of the superior vertebra, and there are two essential causes which come in the way of the functioning of the nerve in the case of stenosis. What happens is we have a growth of osteophyte on the lower end plate of the upper vertebra, or there is a growth of calcified tissue on the tip of the superior articular process.
Now the same has been shown in this patient, where we go in the foramen, we do a foraminoplasty. This is the target tissue, as you can see here in the picture, in the upper part of the foramen at the second last level, and at the end of foraminoplasty you can see this is a foraminoplasty where we have cut the tip of the SAP by going there using a drill, etc. Now this is another patient where the patient has come with a middle zone problem with osteophytes here, which could be drilled away, as you can see in the X-ray in the middle, or it can be curated out with the curates. Now you can see here we are using a drill on the osteophyte, and this is the endoscopic drill. We are going through the scope. The patient is awake, there is no pain whatsoever, and we are able to see it very clearly as if you are operating with an open approach. Now this is under irrigation, and this is the slow moving 525 RPM drill. Now this is another picture which I would like to show you, where you can see the video on a huge screen. Now I am using a curate under the surface of the facet and trying to remove the hypertrophic tissue. So now what we have started doing is we can go in this blue zone, which is the upper zone, as you can see here at L4. This looks triangular, and this is from the lower border of the pedicle to the lower border of the body. We go up in the foramen. The middle zone, which is the orange one, which you can see here at 4-5, and this is the disc level, and the lower zone is the green one, which is here where you have the lateral recess or the lateral part of the canal. So what in short we have done is we have been able to improve the diagnostic process as well as the surgical process, and we are successful. We have been able to relieve our patients with a very, very small group of people who may not be very satisfied with our results, to the extent of about 3% only. And all those complications of dural tear, nerve injuries, vascular injuries, the deaths on table, there is nothing. There are no complications of that sort. So in short, I will summarize. The lessons are, it's a mistake to theorize before you have the data. With proper data, systematic innovation leads to a precise solutions. Read inventive problem solving, and doing the same thing gives the same results. So change, leave the insanity. One small change can have a large effect on the patients. And please remember, your actions make a difference to the people's lives. Always aim higher. I would like you to look at this world's tallest statue of unity. This is something which we have given to the world, and we should also give better results to our patients. Finally, I would bring this to you, which is from our Mission Spine Foundation. Thank you very much for inviting me and allowing me to share my experience and evolution with you. I wish all of you grand success in your future endeavors.